In 2023, the United States spent $4.9 trillion on healthcare. To put that number in perspective, our medical bill is now larger than the entire GDP of Germany. We are currently spending roughly $14,570 for every man, woman, and child in this country, nearly double the average of our peer nations. By every economic metric, we should have the healthiest population on Earth. But we don't. Despite this massive investment, Americans are living shorter lives, facing higher maternal and infant mortality rates, and we're the only high-income population drowning in medical debt. We rank dead last among our peers in access, equity, and administrative efficiency. We are often told this is the price of innovation or simply the market at work. But when you look behind the curtain, you don't find a free market. You find a labyrinth of interlocking corporate boards, a system infiltrated by private equity and gatekept by middlemen you've likely never heard of. What was once a community-focused calling has been rewritten into a high-volume financial asset. The system has transitioned into a rigged casino that prioritizes revenue volume over health outcomes. Today, we're going to perform an autopsy on the American medical system. We are going to uncover the financialization of your health, identify the ghosts haunting medical science, and explore the radical blueprint, from public pharma to behavioral enrollment, that might actually fix it. It's time to see who is actually profiting from your illness. Analogy for understanding. Think of the American healthcare system like a luxury car that costs twice as much as any other vehicle on the lot. But the engine frequently stalls, and the dealership charges you a fee every time you check the oil. You aren't paying for a superior machine, you're paying for the complex, expensive web of brokers and financiers who own the dealership. To understand why medical costs are so high, you have to stop looking at the industry as a free market and start seeing it for what it really is, a collusive labyrinth. We're told these companies are competing for our business, but a massive study of over 2,200 life science companies tells a different story. It found that 10 to 20% of board members are interlocked, meaning the exact same individuals sit on the boards of direct competitors simultaneously. This structure allows companies to coordinate pricing and restrain competition rather than fighting to lower costs for the consumer. But the corruption goes much deeper than the boardroom. It has successfully infiltrated the science itself. We are taught to trust medical journals as the gold standard of truth, but they have been haunted by what researchers call the ghosts. Shocking data suggests that between 50 and 100% of articles regarding new drugs in major journals may be ghost-written. Here's how the scam works. A pharmaceutical firm hires a commercial writer to draft the glowing review of a new drug. Then they pay a prestigious academic position, a key opinion leader, to simply sign their name to the article. These doctors are often paid handsomely for their signature, even if they have never seen the raw data or don't fully understand the drug's risks. The result is a dangerous reality where adverse side effects are scrubbed from the record to ensure high sales. Critics argue this system prioritizes the approval of the most toxic substances because they are profitable, while milder, natural, or off-patent alternatives are ignored for purely financial reasons. You aren't just paying for medicine, you are paying for a scientific narrative that has been bought and paid for by the very companies it's supposed to be regulating. Analogy for understanding. Imagine you are at a high-stakes cooking competition, where the two rival judges are actually secretly married. Instead of judging fairly, they agree beforehand which expensive ingredient everyone must buy. To make sure you believe them, they hire a professional writer to write a 5-star review of that ingredient and pay a famous celebrity chef to sign it, even though the chef never tasted the food. You buy the ingredient thinking it's the best in the world, while the rivals split the profit and hide the fact that the ingredient is actually spoiled. When you look at your receipt at the pharmacy and see a 3-figure or 4-figure price tag, Big Pharma has a ready-made excuse. Innovation is expensive. They claim these astronomical prices are the only way to fund the life-saving research and development of tomorrow. But the math is a lie. If these companies were truly focused on the next big cure, their bank accounts would show it. Instead, major pharmaceutical companies frequently spend double on marketing and lobbying what they spend on actual R&D. Over the last 23 years, the industry has poured $7.6 billion in lobbying alone. To put that in perspective, they employ 3 lobbyists for every single member of Congress. They aren't just selling medicine, they're buying influence. So how do they keep prices so high for so long? They use a strategy called patent thickets. Take the drug Humira, for example. To block cheaper generic competitors from entering the market, AbbVie filed over 200 patent applications. And when a patent is finally about to expire, they engage in product hopping. They tweak the drug just enough to get a brand new patent and then force patients onto the new expensive version. It's a loop designed to ensure competition never stands a chance. But here's the most frustrating part. You are the investor. Through the NIH, taxpayers fund the risky early-stage research for nearly every new drug approved by the FDA. We pay for the invention with our tax dollars, and then we pay again at the pharmacy counter at prices often 3 times higher than the rest of the developed world. You might ask, why doesn't the government stop this? Because of the revolving door. One study found that more than half of senior FDA officials who left the agency ended up working or consulting for the very same pharmaceutical companies they used to regulate. This isn't just about corporate greed. It's a matter of survival. Under the guise of value-based pricing, the price of insulin tripled in just 1 decade. The result? 1 in 4 diabetics have been forced to ration their doses, risking their lives because they can't afford the luxury of staying alive. The profit paradox is simple. We pay for the research, we pay for the marketing, and we pay with our lives, all so the monopoly can stay intact. Analogy for the understanding. Imagine you give a baker all the money to buy flour, ovens, and rent for his shop. Then, when the bread is finally baked, he charges you $50 a loaf while selling it to your neighbor for $10 and uses your money to hire guards to make sure no one else can bake bread in your neighborhood. That is the American pharmaceutical system. As the insurance system becomes increasingly unaffordable, we are witnessing a radical shift in the pharmaceutical industry towards niche markets and what is being called million-dollar math. Instead of long-term treatments, manufacturers are now rolling out one-time gene therapies with price tags that feel like typos. To understand the scale of this new budget shock, look at the current leaders in this new market. Hemgenix for hemophilia B, $3.5 million. Elevidys for Duchenne muscular dystrophy, $3.2 million. Skysona for CALD, $3 million. Zynteglo for beta thalassemia, $2.8 million. The industry justifies these astronomical levels through value-based pricing, arguing that a massive one-time payment for a cure is mathematically cheaper than paying for decades of chronic care and hospital visits. While that logic may hold up in a boardroom, it creates a devastating reality for the families in state Medicaid programs tasked with footing the bill. We are no longer just debating the cost of medicine. We are witnessing a pricing surge that threatens the financial solvency of the entire healthcare system. Analogy. Imagine you're being offered a car that never needs gasoline or maintenance, but the sticker price is $2 million. While the long-term savings are theoretically there, almost no one has the cash to get off the lot, and the bank is terrified to co-sign the loan. The $104 billion takeover. While pharmaceutical companies control what goes into your body, private equity firms are devouring the systems that actually deliver your care. In just over 2 decades, private equity investment in healthcare has exploded from $5 billion in 2000 to a staggering $104 billion in 2024. These firms aren't doctors or healthcare providers. They are financial marauders who view your health as nothing more than a financial asset to be harvested. The strategy? Leveraged buyout. The playbook is simple but devastating. It starts with a leveraged buyout. Private equity firms use massive amounts of debt to acquire physician practices, nursing homes, and hospitals. But here's the catch. They don't carry that debt themselves. They load the debt onto the hospital's own balance sheet, redirecting vital cash flow away from staffing and medical supplies just to pay off high-interest loans. The scam? Asset stripping and rentbacks. Once they own the facility, the asset stripping begins. They use a tactic called a sale-leaseback arrangement. Essentially, they sell the hospital's own real estate, the very land and buildings it sits on, to a third party. Then, they force the hospital to pay rent on the buildings it used to own. It's a parasitic cycle where the facility is bled dry to satisfy investors. The human cost is mortality and cut services. When profit is the only metric, patients pay the ultimate price. To service the debt and increase margins, staffing levels are slashed. In nursing homes, private equity ownership is directly associated with higher mortality rates, decreased patient mobility, and lower quality of care. They don't just cut staff, they eliminate entire departments like maternity wards because they are deemed low-profit services. The precedent? Systemic fraud. This isn't just a case of bad management. It is often systemic fraud. We've seen this playbook before. In 2003, HCA Inc. was forced to pay $1.7 billion, the largest healthcare fraud settlement in history at the time, for defrauding Medicare and paying illegal kickbacks to doctors to keep the revenue churning. Today, the system is even more consolidated. While private equity ravages delivery, pharmacy benefit managers, PBMs, act as the arsonist and firefighter of drug prices, negotiating secret rebates that actually drive costs higher for patients. A system in crisis. The financialization of our healthcare system has turned healing into an extraction business. When the people managing your local hospital care more about debt-to-equity ratios than patient outcomes, the result isn't just a financial crisis. It's a life-and-death struggle for the most vulnerable among us. An analogy for understanding. Think of private equity in healthcare like a group of investors who buy a community's only fire truck with a high-interest loan. To pay for the loan, they sell the tires and ladder and then charge the firefighters rent to use the empty garage. When a fire finally breaks out, the truck can't move, and the investors are already gone with the cash, leaving the neighborhood to burn. You probably think your doctor is getting rich off your illness, but the truth is much darker. Your doctor is trapped. Right now, the US healthcare system is designed for volume, not value. Think about that. Over 80% of primary care pay incentives are based solely on how many patients a doctor can churn through per hour. It's not about how healthy they make you, it's about how many procedures they can bill for. And it starts before they even see their first patient. The average new doctor walks into the clinic buried under over $216,000 in medical school debt. This massive financial weight pushes them away from primary care you need and into high-price specialties just to stay afloat. But the biggest invisible cost is fear. To avoid being sued in the US tort system, doctors are forced to practice defensive medicine. They order a mountain of unnecessary tests, not to help you, but to create a legal paper trail. This fear tax cost our healthcare system an estimated $50 billion every single year. But it doesn't have to be this way. Sweden has already solved this. Instead of a system based on blame, Sweden uses a no-fault model. If a patient is injured, they are compensated through a simple administrative process. There's no need to prove negligence, which means there's no need for expensive lawyers and $50 billion in just-in-case tests. By removing the fear of a gavel smashing their career, Swedish doctors are actually encouraged to report errors. This allows the entire system to learn, improve, and actually keep people healthy instead of just processing them like widgets on a factory line. Analogy for understanding. Imagine a chef on a treadmill. In the US system, the treadmill is set to high speed. The chef isn't paid for how good the food tastes, value, but for how many plates they can slide onto the counter before they collapse. Because they are terrified of being sued if a single crumb is out of place, they spend half their time writing down every ingredient they used instead of actually cooking. In Sweden, the treadmill is slowed down, and if a plate breaks, everyone works together to fix the floor so it doesn't happen again. So, how do we dismantle this machine? The money is already there. We are already spending it. The real question is, do we want that money funding corporate mergers and marketing departments, or the actual health of the American people? To fix this, we have to stop looking at healthcare as a corporate ATM and start treating it as a regulated public utility, just like your water or your electricity. Here are the 4 blueprints currently on the table to dismantle the machine. Blueprint 1. Medicare for All. This is the single-payer heavy hitter. Experts at Public Citizen estimate this move alone would save $500 billion annually just by cutting out administrative waste. Critics claim it would stifle innovation or bankrupt doctors, but the CBO projects the opposite. Provider revenues could actually increase by 5 to 9%. Why? Because we'd eliminate the billing waste that currently consumes 25% of a physician's time and finally cover the millions who currently can't afford care. Blueprint 2. The public option. This lets the government compete with private insurance. It sounds like a safe middle ground, but there's a catch. Reports suggest it could become a dumping ground for the sickest patients, driving up costs because it lacks the massive negotiating power of a full single-payer system. Blueprint 3. Comprehensive Healthcare for America, CHA. This uses behavioral economics to bypass the mandate debate. Under CHA, every citizen is automatically enrolled on day 1. It keeps the current financing but strips away the barriers. No premiums, no copays. For those who still want their own plan, it offers a libertarian opt-out to keep private insurance, ensuring no one falls through the cracks while maintaining choice. Blueprint 4. Public Pharma. If the market refuses to provide cheap drugs, the state simply does it itself. Look at California's Affordable Drug Manufacturing Act. They are bypassing the middleman, the PBMs, to manufacture their own insulin and sell it for $30 a vial. That is a fraction of the current market price, achieved by simply taking profit out of the equation. But blueprints are just paper if we don't change the incentives. Right now, 93.3% of specialists are paid based on volume-driven incentives. The more procedures they do, the more they make. To truly fix the system, we need fixed, competitive salaries. This removes the conflict of interest and the churn environment, allowing doctors to focus on making you healthy instead of seeing more patients. Universal public indemnity. We move to a no-fault system, like Sweden's, where patients are compensated for avoidable harm without a legal battle. This ends the era of defensive medicine, driven by fear. Free medical education. If we eliminate medical school debt, our doctors can focus on primary care and public health, instead of chasing high-paying specialties just to pay off their loans. The transition won't be easy. It threatens the entire private insurance and PBM industry, and it requires a massive workforce retraining. But we have to ask, what happens if we finally take the profit out of healthcare? Analogy for understanding. Think of the current healthcare system like a toll road where every few miles a different private company demands a fee, and if you can't pay, you're kicked off the road entirely. These blueprints propose of turning that road into a public bridge. It's built once, maintained by the community, and everyone gets to cross because the goal is simply to get everyone to the other side safely. The post-profit paradigm. We've been told for decades that fixing American healthcare is too expensive, but the truth is the money is already there. We are currently spending $4.9 trillion on a system designed not to heal us, but to extract from us. Think of it like this. The American healthcare system is an architect who is also the building inspector and the owner of the lumberyard. They design your house to require constant expensive repairs. They approve their own faulty blueprints, and then they charge you triple for the wood. Reforming this system isn't about burning the house down, it's about firing that architect and ensuring the materials are sold at a fair price. It means moving from asset to utility, regulating healthcare like electricity, not a hedge fund's asset. It means moving from volume to value, paying our doctors to actually heal people, instead of just processing patients like units on a conveyor belt. And it means exorcising the ghost, ending the culture of ghost-written science and interlocking directories that have corrupted medical truth for too long. By reclassifying healthcare as a regulated public utility, we can capture the hundreds of billions of dollars currently lost to corporate surplus. We can fund true innovation through medical breakthroughs rather than through price gouging, massive marketing, and lobbying expenditures. Ultimately, the question isn't whether we can afford a better system. The question is, what do we want our trillions to fund? Do we want that money to continue fueling corporate mergers and private equity dividends? Or do we want to fund the actual health of the American people? We cannot fix a broken design by simply pouring more money into it. We have to choose a new design. It is time to choose. If you're ready to take a deep dive into the 150 plus sources that prove this paradigm shift is possible, check the links in the description. Thanks for watching.